So without any delay, I'm gonna like to introduce our first speaker for today's webinar, Professor Simon Marr. And Simon doesn't really need an introduction. Simon is expert in fetal medicine. He is chair of the courses subcommittee and ISUOG, or used to be the ISUOG courses task force. Professor Simon Marr is the director of the Monash Ultrasound in Melbourne in Australia, and he's going to talk to us on cardiac anomalies. So thank you so much, Simon.
Thanks very much, Asma. Do you have my screen?
Yes, we can see your screen.
You can see your screen. Great.
Go ahead.
Thanks very much for that. So I might start my clock. So I'm going to be covering the topic of cardiac abnormalities that you identify in the third trimester of pregnancy. And you will know from the ISUOG guidelines, the third trimester, that 14% of cardiac abnormalities are identified in the third trimester. And that's a pretty significant statistic, and therefore becomes important when assessing the heart and the third trimester that we do a dedicated assessment. So why? Well, in a sense, we're looking for lesions that we've missed at the mid-trimester, subtle lesions, for example, anomalous pulmonary venous return or ventricular septal defects. But there are also anomalies which we'll never see early in pregnancy, such as the evolving lesions, cardiorhabdomyoma by way of example. And then there's the valvular lesions, which some of these evolve over time, will not be evident the first, second trimester, but will evolve in the third trimester. A classic example is pulmonary stenosis. And then there's extracardiac abnormalities such as renal disease, sacrococcygeal teratomas, and lumps and bumps that evolve that cause cardiac strain. And I'll be covering it in that format in the lecture today. So if you ask me, you say, Simon, let's look at the cardiac anomalies. And if you look at this study from Kypros Nicolaides' group, that of ventricular septal defects, about a fifth of them are seen in the third trimester for the first time. Valvular defects across the tricuspid valve, about a third of them. And in fact, the rhabdomyomas, the vast majority are seen for the first time in the third trimester. And then the outflow tract anomalies, I've listed the percentages, but you can see for all of these, a very significant proportion of cardiac abnormalities are identified in the third trimester. You need to know what the specific anomalies are by looking at this page and maybe coming back to it later, because it's important to target these areas within the heart when doing a third trimester scan. So let's start with the VSDs. We know that many ventricular septal defects are not evident on 2D. So when we go from a long axis to a short axis, nothing is seen in this patient in the third trimester. But as soon as we put on color Doppler, we see that there's a ventricular septal defect. You may say, oh, what's the big deal? It's a muscular ventricular septal defect. Well, with any defect in the heart, you need to then extend it to see if there's evidence of co-arc or any other markers with the VSD within the heart to suggest something far more fundamental. But also you need to assess the size of it and reference it to the size of the aorta, because a significant number of these, particularly the large ones, will require surgery after birth. Far more difficult to pick are the perimembranous VSDs in the second trimester. You may see it for the first time during a growth scan. And when you look at this, you say, wow, that looks like a tetralogy of Fallot. But when you look at the outflow tract, you see a normal pulmonary artery, a normal aorta, normal references in size, with no evidence of infundibular or pulmonary valvular stenosis. This is a perimembranous VSD, slightly malaligned, an important group because 25% of these require surgery within the first 5 years of life, and therefore this baby needs to be tracked after delivery. What about the tricuspid valve? We all know that tricuspid valve regurgitation is common in the trimester. It's even more common in the third trimester of pregnancy. So let me put this case by you and challenge you. And I say, if you were to go to work tomorrow morning and see this patient with severe tricuspid valve regurgitation, it hits the roof, it's a focal jet arising from the tricuspid valve, and then you put on a pulse Doppler gate and you see velocities up to 3 meters a second. I know what you're going to say. You're going to say this is severe regurgitation and there's an underlying cardiac defect. Let me stop you right there and show you the clip on the right-hand side, because that's the same baby 3 weeks after delivery. I'm starting off by showing you an example of severe tricuspid valve regurgitation in the third trimester that is not synonymous with a cardiac defect. After birth, the pulmonary vascular resistance drops, the compliance in the ventricles improves, and tricuspid valve regurgitation resolves. A very important point. On the flip side of the coin, let me show you another case. This is post-lasering of a twin pregnancy in the recipient twin. There is no flow across this pulmonary artery. The pulmonary artery size looks fine, reference to the aorta and SVC, but this baby has got pulmonary atresia. And when I look across the tricuspid valve, it's got really mild regurgitation. And when I look at the velocities across the tricuspid valve, it's only 130 centimeters a second. So what am I saying? Is the severity or the lack of severity of regurgitation does not necessarily indicate severity of underlying disease. It's a misconception that has existed for years. In a sense, the way you need to look at tricuspid valve regurgitation is to look at, number one, subjectively. What is the actual length and area of the atria? And you can do this by simply playing cine loops of mild, moderate, and severe. And then you need to objectively assess it to see whether it's early systolic, mid-systolic, or pan-systolic across these three clips. The point I'm making is that when you see regurgitation, you need to do two things: subjectively assess it and then objectively assess it. And you can come back to this clip later and play these and just watch the spectral pattern compared to the color Doppler pattern. Once you've done the subjective and objective assessment, before you make any call about severity of anything, you go through 4 steps. 1, you check the AV valve for tricuspid valve dysplasia or Epstein's. 2, you check for right ventricular outflow tract obstructions, such as pulmonary stenosis or duct constriction. 3, you check that there's not cardiomegaly stretching the valves apart, giving rise to tricuspid regurg. And then 4, you look for evidence of fetal anemia or volume overload. Only when you've gone through those 4 steps can you then gauge, after subjective and objective description of the regurgitation, whether it's something you're concerned about or whether it's a benign variant. What about cardiomegaly? Well, you know, this is something that we see pretty regularly in the 3rd trimester of pregnancy. And if you actually look at the ISUOG guidelines, you ask yourself, hang on, what is the recommendation? Do we measure the area of the heart to chest, diameters, circumferences? I think we should measure circumferences. When you look at the cardiothoracic circumference ratio, I know the guideline says 50%, but that's going to give a very high proportion of fetuses with 50%. In general practice in our unit, we use 60% for the CTCR ratio. And when you see that there's enlargement of the heart, by way of example, these 2 clips, then you look at this differential diagnosis on the left-hand side of the page. So when you see enlargement of the heart, you need to do a target assessment for these specific markers. Most importantly, look at valvular flow, laminar flow across the AV valves and the outflow tracts. So to run through examples that you'll be faced for the first time in a baby or a mother who's had a completely normal scans leading up to this would be myocarditis, supraventricular tachycardias, tricuspid valve dysplasia, major cardiac abnormalities, in this case, Epstein's, a dilated cardiomyopathy in case of the scenarios of the metabolic diseases, or in this case where a cardiothoracic ratio is raised, not because the heart's enlarged, but rather the chest is constricted in the setting of a skeletal dysplasia. These are all individual, unique causes that may present for the first time in the 3rd trimester of pregnancy. So it's important to become used to measuring cardiac size. What about tumors? These are unique in a sense in that they've seldom present in the mid-trimester and never present in the 1st trimester. Nobody will make a mistake in a diagnosis of a cardiac rhabdomyoma in the 1st case, 2nd case, or the bottom left-hand corner of the 3rd case. But you've got to be careful because there are many examples I can't show you today which borderline appearances may look like a cardiac rhabdomyoma, particularly with respect to the moderator band. This is not a cardiac rhabdomyoma. This is a normal moderator band. And in some of these will require review again later in the 3rd trimester to ascertain whether they are single or multiple. Why would I worry about cardiac rhabdomyoma? To be honest with you, I don't, because cardiac rhabdomyoma pretty much universally resolve after birth. What I do when I see a cardiac rhabdomyoma and I think it's solitary, I then take out a high frequency transducer because pretty predictably it's not solitary. there are other more smaller rhabdomyoma, and they don't exist in the atria as a general rule. They exist in the ventricles. Why am I not worried about them? Because they very rarely cause obstruction prenatal. I know it's described left and right ventricular outflow tract obstruction, but in 30 years of practice, I've never seen that happen. I know they resolve postnatally. The problem is that these babies are associated with the gene mutation leading to tubular sclerosis, the TCS2, one gene mutation, which is 80%, which carry a worse prognosis, or the familial form, which is the TCS1 gene mutation. And in a sense, this is a highly variable outcome and extremely difficult to counsel mothers because it can vary from normal or minimal adverse effect to severe intellectual disability, autism, epilepsy, and so on. So it's important in these babies to look at the brain because that's what I worry about. This is a baby with multiple parenchymal tubers on the right and left side and posterior to the cavum septum pellucidum. So it's when I see tubers in the brain in these babies, that's when I get concerned about tuberosclerosis. What about doing a third trimester scan and seeing discordant ventricles? Well, you all know you're faced with that when you go to work tomorrow morning. It's part and parcel of a routine practice. You see that the right ventricle is bigger than the left. So when you look through these examples of discordant ventricles where there's pathologies, in the first, coarctation. In the second, total anomalous pulmonary venous return. In both of these, the right ventricle is larger than the left. In this one, persistent left superior vena cava, you can see the left ventricle is smaller than the right. Mild aortic stenosis, aortic interruption with a posterior malaligned VSD, and diaphragmatic hernia causing a compression effect with a small left ventricle. In all of these cases, you look at them as being a small left ventricle or a large right ventricle. These are the differentials that are running through your head when you're seeing ventricular disproportion. But for the vast majority of cases that you see ventricular disproportion are normal variants. And you look at that clip and you say, Simon, how do you know that's normal and not any of the previous 6 differential diagnoses I've just given you? I'll say to you, I do 2 simple things. I look, first of all, at the 5-section analysis of the heart, ensuring the integrity of all the normal structures are present. But most importantly, I look to see that there's laminar flow across the AV valves, and then I see that there's laminar flow across the semilunar valves. If I'm concerned after that, only then would I go ahead and do objective assessment. And what is objective assessment? Well, you take the size of the level of the mitral or tricuspid valve, or you can measure the length of the ventricular chambers. But in routine practice, I don't do that. I simply accept that the left and right ventricle are equal in size up to 22 weeks. I simply accept that the right ventricle is larger in a ratio of 1:1 and independent of gestational age using that figure. And if I get a normal inflow in a 4-chamber view of heart and a normal outflow in a 3-vessel tracheal view with laminar, then I sit easy with ventricular discordance, but I do go through that process. Then I'd look at the abnormalities of the outflow tracts, and from the very original slide that I showed, these are the proportion of the anomalies that are picked up. So 1/3 of coarcs are picked for the first time in the 3rd trimester. And then pulmonary stenosis, which is really a very disappointing figure that we only pick up 15 because most pulmonary stenosis are picked up after birth. And I think we can greatly improve on that figure. Aortic stenosis is a much rarer condition, and about 1/3 of these will be seen for the first time in the 3rd trimester. Now, why is coarc so challenging? Well, I guess there's no one particular measurement that's of any use in coarc. And I guess when you see anything that's challenging, you'll find that there's plenty in the literature describing various markers. And that's a single-page snapshot of all the markers that have been described to help us detect coarctation. And how good are they? Well, to be honest with you, they're not great at all. A recent publication, the White Journal, concluding that the diagnostic accuracy is only moderate, even when you combine these multiple parameters. So it's very challenging. The ones marked in the yellow are the ones that we use in routine clinical practice. An isthmus Z score is less than 2, and the isthmus to duct diameter of less than 0.7. So in a sense, when you're faced with that ventricular discordance, the laminar flow looks fine across the AV valves, looks fine across the semilunar valves. How am I going to pick up coarc? Well, if it's tubular, it's easier, but when it's focal like this, where you have a narrowing at the level of the isthmus, that's where I take out and I measure the Z score. And when I'm borderline, am I concerned about it, it may require a repeat scan. But the next step is then to go to a sagittal image of the arch, and now I can see the focal coarctation. There's a whole lecture on this subject. I'm covering it in 30 seconds, but it's extremely challenging with a high false positive and a high false negative rate, particularly for the single example I've shown you today of the focal coarctation. What regard to pulmonary stenosis, I sort of, it's a depressing abnormality because I feel we miss it. I don't think there's anybody in this room tonight watching this clip who would ever doubt a diagnosis of pulmonary stenosis. A big, chunky, dilated pulmonary artery when compared to the aorta, post-valvular dilatation with turbulent flow, with a thickened pulmonary valve, tricuspid valve regurgitation, and then velocities up to 3 meters a second. That is a full lay-down Mézières deck of cards of a severe pulmonary stenosis. But the problem is the pulmonary stenosis that we miss are mild. And I think the reason we miss them is because we don't look at the free wall of the right ventricle when we're looking at the right ventricular outflow tract. We don't get a good view of the pulmonary valve. And I think many of you, if you went to work tomorrow morning and did a growth scan and looked at that 3-vessel view, you'd say, oh, that looks pretty okay. The pulmonary artery is larger than the aorta, is larger than the SVC. But if you set your pulse, Doppler, and color settings correctly, you now begin to realize that there's turbulent flow. You now begin to appreciate the pulmonary valve does not disappear completely during ventricular systole. I think we can improve. So you go to work tomorrow morning and you see this case, you reference it to the aorta as the first step, and then you place a pulse Doppler gate over the valve, and if it's greater than 100, you're concerned. With regard to aortic stenosis, yeah, look, these are uncommon. Post-valvular dilatation, very similar to the first case of pulmonary stenosis I showed you. And when you look at the pulse Doppler velocities, you're getting velocities up to 3 meters a second. But ultimately, for the more milder cases, it's just color that you will see turbulent flow on routine imaging with no dilatation. These, like the mild pulmonary stenosis, are far more challenging. But unless you do a dedicated color assessment, you won't pick them. Transposition of the great arteries, we all know how important it is to make this diagnosis because the benefits in terms of outcomes, if you know about things prenatally. We've reported on the sign in the first trimester of a 4-chamber view of heart, then sweeping up to the 3-vessel tracheal view and seeing the reverse boomerang. We also reported it as a sign marker in the second trimester across 19 consecutive transpositions of the great arteries. But you know, in the third trimester of pregnancy, sometimes this rule of thumb lets you down on 2 accounts. This is a baby with TGA, but you can see how easily it would be missed because as you sweep up to the 3-vessel tracheal view, there are 3 vessels. And actually there is, when you look at it, the curvature of the right ventricular outflow tract is far less striking when compared to the second and third trimester. The only reason you will pick this up is because as you sweep from the 4-chamber up to the 3-vessel view, you appreciate that the first vessel you see is a bifurcating pulmonary artery. That should never be the case. Remember, when you sweep up to the neck, the first vessel should always be the aorta. But it's very challenging TGA. I'll finish with the last group, the miscellaneous group. So these are cases where you'll get cardiac enlargement, ventricular hypertrophy in the setting of bilateral renal disease. I'll start with a striking one. So this is a patient with infantile polycystic kidney disease, and these will present around the mid-trimester or a little bit later. But for the lower urinary tract obstructions or the urethral atresias, these may present a lot later. And in this case, you can see severe pelvic calyceal dilatation in this fetus. And when you go to the contralateral side, you see marked calyceal dilatation. And then when you come down to look at the bladder, you can see the bladder wall is thickened. And then when you look into the abdomen, you can see that there's ascites and free moving loops of bowel. But when you then jump to looking at the heart, you see that the heart's got that classic appearance that you get in luto with that ventricular thickening, and they get a cardiomyopathy. And there's a nice review of this by Fiesta and colleagues, saying that it's, or assuming that it's a disruption in the renin-angiotensin system. So in a sense, a form of fetal hypertension that leads to these changes in renal disease. The other miscellaneous group is you go to work tomorrow morning and you look at you're trying to get a ductus venosus. And I know many of you in the maternal-fetal medicine units, when trying to get a ductus venosus, do so in a transverse section. And as you do so, you see that the IVC is dilated with a yin-yang effect. And if you ever see that, that's a feature typical of absent ductus venosus. And it's a very helpful marker, understanding the size of the IVC, what it should look like. And that's the first thing that gets you. And these present in the third trimester of pregnancy. The other scenario you may be faced with, either you see the dilated cardiomyopathy first with tricuspid valve regurgitation, or in this case, it was the chorioangioma that was seen first with a large chorioangioma with cardiomegaly. Similar scenario in this case, a high volume overload of the heart with the globular appearance to the heart at 28 weeks in a fetus that has a sacrococcygeal teratoma. And another example of volume overload with cardiomegaly, tricuspid valve regurgitation in a fetus with a vein of Galen aneurysm. So remember these specific or unique abnormalities that result in a huge increase in the circulating fetal blood volume that the heart is simply not able to cope, and you get a dilated cardiomyopathy, and tricuspid valve regurgitation in the early stages may be the first thing that strikes you. Lastly, in the miscellaneous group is the group of twin-to-twin transfusion syndrome. And there are several individual changes that are just described in sequential order, from ventricular myocardial hypertrophy, particularly on the right side from pulmonary stenosis in the recipient twin. It then follows with biventricular hypertrophy. Then you get cardiomegaly. Then you get ventricular hypokinesia, atrioventricular dysfunction with tricuspid valve regurgitation, and then obstruction of the right ventricular outflow tract. Well, if you look at these 5 changes, you see this baby with twin-to-twin transfusion syndrome has got them all. It's not just right ventricular hypertrophy, it's left ventricular hypertrophy. There's globular cardiomyopathy, there's tricuspid valve regurgitation, and there's pulmonary valve stenosis with both pulmonary turbulence and pulmonary regurgitation. This baby has the full house of what you see in twin-to-twin transfusion syndrome. So in summary, the cardiac findings in the 3rd trimester are either subtle lesions, evolving lesions, or valvular lesions. And I think if you know the specific group, and if you see the scenario where you've got cardiomegaly, tricuspid regurg, consider the extracardiac anomalies where you're looking for renal disease, sacrococcygeal teratomas, vein of Galen aneurysms, or chorioangioma. So I ask you at the end of this talk, what difference does this talk make to you tomorrow morning? Well, I hope I've convinced you that, first of all, it's important to do a cardiac scan if 14% of cardiac anomalies can be identified in 1st trimester. Don't do a quasi 2-second cardiac assessment, say I can see a heartbeat. Do a dedicated 4-segment screening analysis of the fetal heart, exactly as you would do in a mid-trimester examination, and you will pick these cardiac abnormalities. Before I finish up, I'd just like to say to you, it's not too late to register to the course that we just ran recently in Dublin. This is still available on demand, and the details of this are available on this barcode. Thank you very much for your attention.
That was fantastic, Simon. Thank you very much. Brilliant talk as usual. And really just reiterate the recommendations about the cardiac assessment in the ISUOG 3rd trimester ultrasound guideline, where the guideline recommends it's not just doing a biometry or gross scan, but also looking at the fetal anatomy and looking at the cardiac views, similar to what is recommended in the ISUOG guideline on fetal cardiac assessment, as Simon mentioned. So thank you so much. I'd like